Welcome to Deep Dive Ortho. Today we're exploring something that really changes the game for patients undergoing total joint arthroplasty, TJA. The surgery itself, it's incredible, but we're focusing on that crucial preparation phase, which often gets overlooked. Our mission is a deep dive into how proactive patient optimization before TJA can really boost outcomes and, importantly, cut down risks. We're talking about going beyond just ticking a clearance box to achieving, well, genuine optimization. And guiding us through the evidence is Prof. Mo Imam. Prof. Mo Imam, it's great to be here. This shift in thinking is absolutely vital for us as orthopedic professionals and, of course, for our patients. So let's unpack this shift we're seeing. For ages, it felt like the goal was simply getting patients cleared for surgery. Now it's about optimization. What's really driving that change? Prof. Mo Imam. Exactly. Traditionally, clearance was about assessing if someone was safe for the procedure, but this move towards optimization, it's much more comprehensive. It's about actively mitigating poor outcomes. Okay. Prof. Mo Imam. And it's not just a clinical preference, I should add. It's heavily influenced by value-based care, bundled payments. These things really force us to focus on getting the best results efficiently, delivering real value, right? The value aspect. So what happens if we don't optimize? What are the real-world consequences? The things clinicians need to really grasp. Prof. Mo Imam. Oh, the consequences are quite stark, really. If you don't optimize, you see higher risks for, well, everything. Deep infections, superficial ones, PEs, MIs, more readmissions, longer hospital stays, higher costs, and yes, even more revisions. Wow, Prof. No Imam. There was research, Przansky's group, I believe, suggesting something like 80% of TJA patients have at least one risk factor we could potentially modify. And think about PJI, periprosthetic joint infection. The 5-year mortality rates are just devastating, around 21% for hips, 22% for knees. That's incredibly high. Prof. Mo Imam, it is. So ignoring optimization doesn't just slightly increase risk. It can lead to this cascade of very costly, sometimes life-threatening problems that undermine the whole point of the surgery. Those figures really hit home. It underlines just how critical this phase is. And it seems the orthopedic surgeon's role is changing too. We're getting more involved preoperatively. Prof. Mo Imam. Absolutely. Our role is much more integrated now. We're not just the technicians in the operating theater. We're involved in managing these modifiable conditions before surgery, setting up protocols, identifying risks. Prof. Mo Imam, it's about taking a more holistic view of the patient's journey, from that first meeting right through recovery. We need to actively guide their preparation.
Okay, that makes perfect sense. So we understand the why. Now let's get into the specifics, the what's. This is where it gets really interesting. Digging into those factors that makes such a difference. Let's start with diabetes. What's the current thinking on managing blood sugar before surgery? Prof. Mo Imam. Diabetes is a big one. And it's quite surprising, actually, that a fair chunk of patients, maybe a third or even up to 40%, are newly diagnosed when they come for their pre-op checks. Really, that many. Prof. Mo Imam. Yes. So routine HbA1c screening is crucial. That's the measure of average blood sugar over the last couple of months.
The evidence shows that an HbA1c over 6.7% increases the risk of wound problems. Now, the target varies a bit, but generally we aim for under 8%. Okay, Prof. Mo Imam. But what's really key to understand, something Harris highlighted back in 2013, is that the risk doesn't just suddenly appear at a certain threshold. It increases linearly with HbA1c. So it's a sliding scale. Prof. Mo Imam, exactly. Any improvement helps. We also see optimal PJI thresholds cited around 9.7% for knees and 7.8% for hips. Sometimes tosamine is used too for a shorter term picture, maybe 14 to 21 days. Levels over 292 micromoles per liter, that corresponds to an HbA1c around 7%, are linked to higher risks of deep infection, readmission, reoperation, right? Prof. Mo Imam. So most places recommend getting that HbA1c down to 7.5% or lower before going ahead. It's about finding that balance. That linear relationship is such an important message. Every bit of improvement counts. Okay, moving on to obesity, another huge challenge. What are the specific risks here, and what weight management strategies are actually working preoperatively? Prof. Mo Imam. Obesity significantly ramps up risks post-op. We see more acute kidney issues, cardiovascular problems, wound complications, infections, readmissions, reoperations. It's quite a list. Prof. Mo Imam. For patients with morbid obesity, a BMI over 40, the risk can be 2 to even 6 times higher. And while 40 is a common cutoff in studies, remember, it's a continuous scale. Sure, Prof. Mo Imam. The evidence on exactly how much weight loss is needed can be a bit mixed, but generally, losing more than 5% seems beneficial. Keeney's study, for example, found morbidly obese patients losing at least 20 pounds before TKA had shorter hospital stays. That's tangible, Prof. Mo Imam. It is. And nutritional counseling programs can be really effective. One study, Lingenfelter's, showed 92% of participants lost weight, and nearly 2/3 got their BMI below 40. That's impressive, Prof. Mo Imam. But it takes time. A recent study by Dietz found BMI optimization took the longest average over 220 days. And interestingly, patients starting between BMI 40 and 45 were actually at higher risk of their BMI increasing before surgery. Oh, really? That's counterintuitive. Prof. Moimam, it is. So the strong advice is for BMI 40 or over, consider delaying surgery until it's reduced. It's often a long haul for these patients. A long haul, definitely. Good to manage expectations. Okay, beyond sugar and weight, let's talk nutrition, or rather, malnutrition. Hypoalbuminemia, low protein levels. How does that impact things? Prof. Moimam. Malnutrition, often flagged by low serum albumin, less than 3.5 grams per deciliter, is a really strong independent predictor of complications. Independent, okay. Prof. Moimam. Yes, we're talking higher mortality, surgical site infections, breathing problems, heart problems, bleeding, sepsis, PJI, readmissions, reoperations, longer stays, the works. Bull highlighted this back in 2016, right? Prof. Moimam. And interestingly, it's more common in obese patients, and FU's research suggested it can actually be a stronger predictor of problems than obesity itself. No. Stronger than obesity. Prof. Moimam. Yes. Other lab markers to watch are low transferrin or a low total lymphocyte count, but it's not just labs. Interview tools like the mini nutritional assessment, the MNA, can also help predict risk, as Isla showed. Prof. Moimam. And the good news is interventions help. High-protein diets, anti-inflammatory approaches like Schroer studied, or essential amino acid supplements like Oyama looked at these, can improve outcomes. So assess thoroughly and, if needed, delay to optimize nutritional status. So a good nutritional history and assessment are key. Okay, anemia. Very common. What are the specific dangers for TJA patients, and what's the latest on managing it? Prof. Mo Imam. Anemia, so that's hemoglobin below 12 for women, 13 for men, is quite prevalent in our TJA patients, and it's clearly linked to needing more blood transfusions, more reoperations, and a whole host of systemic problems, wound issues, lung, heart, kidney complications, sepsis, longer hospital stays. Go's work laid this out clearly. And transfusions themselves carry risks. Prof. Mo Imam, exactly. Transfusions aren't benign. They're independently linked to more complications and higher costs. That's why groups like NADA, the Network for Advancement of Transfusion Alternatives, strongly recommend getting hemoglobin levels checked about 28 days before surgery. Right, plan ahead. Prof. Mo Imam, precisely. Screening for and treating anemia preoperatively demonstrably cuts down transfusions, readmissions, length of stay, and costs. So the recommendation is clear. Delay surgery until hemoglobin is optimized to the recommended level. It's a very modifiable risk with big benefits. Makes sense. Identify early, treat proactively. Let's switch gears to smoking. Still a major issue. What are the risks for smokers having TJA, and are cessation programs actually effective? Pro Mo Imam. Smoking definitely increases risks. We see more wound complications, more PJI, lower respiratory tract infections, heart attacks. Patients tend to use more opioids, and there's even a higher risk of implant revision down the line, as Singh showed. Quite a range of issues. Prof. Mo Imam, it is. But the positive side is that intensive stop smoking programs work. Things involving counseling, nicotine replacement, they really can reduce smoking rates and, importantly, complication rates. Miller's study demonstrated this quite well. Okay. Prof. Mo Imam. And using cotinine testing, that's a nicotine metabolite test, can actually boost self-reported quit rates and catch those who might say they've stopped but haven't. Verification. Prof. Mo Imam, yes. So the standard recommendation is stop smoking at least 4 weeks before and 4 weeks after TJA, ideally confirmed with a negative cotinine test. Give the body its best chance to heal. 4 weeks is a commitment, but clearly worthwhile. Okay. Finally, opioid use, a huge public health challenge, and it really impacts our patients. What does the evidence show here? Prof. Mo Imam. Preoperative opioid use is linked to a lot of negative outcomes. Longer stays, less chance of going straight home, more 30-day unplanned readmissions, more surgical site infections, more revisions, higher costs, and poor rates of actually stopping opioids after surgery. Blevins Pratikos covered this extensively. Prof. Mo Imam. And for patients with diagnosed opioid use disorder, the risks are even higher. Things like in-hospital mortality, PJI, clots. Plus, pre-op opioid use is associated with worse patient-reported outcomes, meaning they just don't feel they do as well, as Goplin found. So it affects their subjective recovery, too. Prof. Mo Imam. Absolutely. But here's a crucial point from McGeehan's research. Reducing preoperative opioid use by 50% can lead to outcomes similar to patients who weren't using opioids beforehand. That's a really powerful finding. 50% makes that much difference. Prof. Mo Imam, it seems so. It makes weaning efforts really worthwhile. And guidelines from AHKS and ACR generally caution against non-tramadol opioids for hip and knee OA anyway. So the advice is aim to wean off opioids by at least 50%, ideally starting at least 4 weeks before surgery. And of course, use non-opioid pain relief strategies wherever possible. That 50% reduction is a really practical, hopeful target. Okay, so we've tackled the why and the what's, the individual factors. Now, thinking bigger picture. How do we weave all this together? What about other strategies around the surgery itself? Let's start with patient counseling. Why is that so important beyond just explaining the mechanics of the operation? Profmo Imam. Counseling is crucial primarily because patient satisfaction hinges so much on realistic expectations. Patients, understandably, can be overly optimistic about how quickly they'll recover or how much pain relief they'll get. Profmo Imam. So, setting accurate expectations preoperatively about pain, function, potential bumps in the road is absolutely key. And it's not just about the surgery. Assessing their social support beforehand allows us to, well, optimize that too, and it helps hugely with discharge planning. That impacts length of stay, readmissions, whether they can go straight home. Right, prepares them for the whole recovery arc. Profmo Imam, exactly. It's about the entire journey. Makes sense. Okay, VDE prophylaxis, preventing blood clots, always a tricky balance. What are the key things to weigh up and what are the current recommendations? Prof. Morimam, it absolutely is a balancing act. You're weighing the risk of bleeding from the anticoagulants against the risk of a VTE, a clot, which can have serious consequences, even mortality. Sure. Prof. Morimam. Guidance comes from groups like the ACCP. They suggest mechanical compression devices plus a pharmacologic agent like warfarin, LMWH, aspirin, factor XAT inhibitors. There's several options. The AAOS approach is maybe a bit broader. A drug, mechanical compression, or both for patients without major VTE risk factors.
Yeah.
Okay. Prof. Morimam. In practice, many surgeons lean towards aspirin. It's oral, compliance tends to be good, it's inexpensive, and the bleeding risk profile is generally favorable. But the key is always tailoring it to the individual patient's risk profile.
Individualized approach, right?
And what about anesthesia and pain management? Seems like multimodal strategies are the way forward now. Prof. Moimam. Definitely. For anesthesia, neuraxial techniques like spinal anesthesia are often preferred. The thinking is they cause less physiological stress than general anesthesia. And some retrospective studies suggest links to shorter surgical times, lower infection rates, fewer cardiovascular events, less need for transfusion, shorter stays. Quite a few potential benefits. Prof. Moimam, indeed. And for pain management, yes, it's all about the multimodal approach. The aim is good pain control to get patients moving early, improve their reported outcomes, and shorten their stay. We see benefits from preoperative NSAIDs, Colobex-2 inhibitors specifically, and pregabalin, helping reduce opioid need and improve motion. Rav Moimam. Then there are periarticular injections, that cocktail of local anesthetic, maybe some opiates, NSAIDs, injected around the joint during surgery. They're proving a really effective alternative to femoral nerve blocks for knees, often cheaper, safer, easier. Okay. Prof. Moimam. For hips, too, they can cut opioid use and improve pain and function. And briefly on nerve blocks, the adductor canal block for knees is advantageous because it gives pain relief without the quad weakness you get with the femoral block, which helps with early mobilization. So more tools, better targeted pain relief. It seems clear putting all this together requires a structured approach. What's the evidence that these kinds of optimization programs actually work and are sustainable? Prof. Mo Imam. The evidence is definitely growing and supports these structured, often surgeon-led programs. That Dietz review we mentioned earlier, looking at nearly 900 TJA patients, only 3.5% were fully optimized at the first visit. 96.5% had room for improvement somewhere. Huge potential then. Prof. Moimam. Massive. And the average time to get at least one factor optimized was about 6 months, 188 days. Remember, BMI took the longest, HbA1c the shortest. But crucially, over 93.5% kept or improved their optimization status between that pre-op visit and surgery day. That's great. They maintained the gains. Prof. Moimam. Yes. And even better, these surgeon-led efforts within a TJA program showed sustained benefit maintenance or improvement for over half the patients up to a year after surgery. And another study, Sigurdarartortyr's prospective work, reinforced that structured optimization lowers the risk of superficial surgical site infections. So yes, it's sustainable with the right program. That's really encouraging the effort pays off long term. And with outpatient TJA booming, what does that mean for optimization? Prof. More Imam. That's a key point. Outpatient PJA has grown incredibly fast from 15% in 2016 to maybe 43% now, heading towards potentially over half of cases soon. Wow. Prof. Moimam. And while studies show it's safe and feasible, that rapid turnaround makes optimization even more critical. You need really careful patient selection, the facility needs to be ready, surgery efficient. Without robust pre-op optimization, the risks in an outpatient setting would surely be higher. It basically becomes essential, non-negotiable for outpatient, really. Okay, this leads to some practical points for our listeners. All this extra pre-operative work, is there reimbursement for it? Prof. Moimam. A very important question for practices. Fortunately, yes. There are mechanisms like principal care management codes, PCM codes. If you meet the CMS criteria, these codes allow surgeons to be compensated for the significant time and effort involved in this detailed preoperative planning and optimization. Good to know, Prof. Mo Imam. It acknowledges the value delivered outside the operating room. Definitely. Which brings us to a difficult ethical question. Balancing the patient who's in severe pain from end-stage arthritis against this need to optimize, which might mean delaying surgery. How do we navigate that? Prof Mo Imam. It's a genuine ethical tightrope we walk. You absolutely recognize the patient's suffering, their pain is real and debilitating, but you also have to weigh that against the principle of first, do no harm. Prof Mo Imam. Given the significantly increased risks of really bad complications like PJI with its high mortality and life-altering impact going ahead without addressing modifiable risks could arguably violate that core principle. Thorough optimization is fundamentally about maximizing safety and ensuring the best possible long-term outcome. Sometimes that temporary delay, while difficult, is a necessary investment in the patient's future health and the surgery's lasting success. It's about their best interest in the long run, a really crucial perspective. Well, this deep dive has certainly illuminated that vital shift towards proactive optimization in TJA, covering the key factors and the benefits of this comprehensive approach. So perhaps as you approach your next elective arthroplasty patient, the question isn't just are they cleared, but how truly optimized can we get them for the very best outcome? If you found this deep dive insightful, please do take a moment to rate and share Deep Dive Ortho with your colleagues. It really helps us reach more professionals like you. Prof Mo Imam. I think the future here is clear. It's moving towards ever more personalized, proactive patient preparation. It's not just about managing downside risk. It's about genuinely enhancing every patient's potential for a full, successful recovery and improving their quality of life.